Thanks for joining me today. Today's topic is about various testing options for perimenopausal women. Over the years, working in this space, I started to realize that the perimenopausal cohort was often overlooked. Women are often grouped into premenopause and menopause, whether they're cycling or not cycling, essentially. But this transition stage is pretty impactful. There has been a lot more chatter about it on some of the socials in recent months, maybe a year or so, and that makes me happy because I do think that this cohort is really a unique time for us to make some interventions and help improve health, um, both for the now and for what they are potentially facing in terms of pathologies that are more common after we move into menopause. So there are a lot of tests that providers might consider for this cohort. So my intention today is to do a brief overview of some of the ones that I have found to be of primary consideration in my perimenopausal patients. So here's our learning objectives for today, but I just wanted to point out that really what I'm talking about is how to address the symptoms that these women are experiencing now, but also how to be proactive with disease prevention. So what does perimenopause mean? I'm talking about natural menopause here, not, induced by surgery or chemo or something like that. But natural menopause, the average age is 51. That means that there's a continuum, right? That normal menopause can occur between the ages of about 40 and 58. And because the physical changes leading up to menopause can begin years before this change, 4 to 8 years on average, that means that perimenopause could start at about age 32 in some women. So menopause is 12 consecutive months without a period, but the years leading up to that can be maybe 8+ years long, and we can see a lot of symptoms begin to develop in that time. These are some of the symptoms we might expect to see. Now, you're familiar with these, I know. For some lucky few women, they won't have any symptoms at all except irregular men's season and eventually stops when they reach menopause. For the women who do have symptoms, sometimes these symptoms will appear gradually and slowly worsen as the years go by. And in other women, these symptoms can really appear suddenly, almost as if out of thin air, when they really haven't done anything differently in their lives. And this is when women sort of start to feel crazy. They can feel overwhelmed and confused. So it's our job as physicians not only to help them manage their health, but to also let them know that they're not crazy. These are real physiological changes that drive these symptoms, and there's a lot that we can do to help them. So testing to determine hormone imbalances and then addressing them with menopausal hormone therapies and supportive therapies can make a big difference in our patients' symptoms. But I also want you to consider how it can help the development of certain pathologies that are more prevalent in menopause. So cardiovascular disease, we know, is the #1 killer of women. And by age 70, women have about the same risk for heart disease as men of the same age. Risk for stroke doubles every decade after age 55. And a key reason is that while we have a lot of estrogen, our blood vessels are flexible, they contract and expand to accommodate blood flow. But when estrogen levels start to diminish, this benefit is lost. We know the atherosclerotic process accelerates greatly in this perimenopausal time. And also women who have frequent and persistent hot flashes earlier during the transition also seem to have a higher risk for developing cardiovascular disease. Before menopause, women's bones are protected by estrogen, but in this transition, bone loss can become very rapid. And just like we saw previously, women who have very severe hot flashes and night sweats in this perimenopausal time often have more bone loss. And so they're at higher risk for hip fractures than women who don't experience these same severe symptoms. Estrogen loss can lead to hip fracture. The Framingham study showed a 50% drop in osteoporosis hip fracture for women who were doing estrogen therapy. Postmenopausal osteoporosis and related fractures is a serious health issue because when women have hip fractures, This leads to long-term disability and morbidity and even death. Other hormones are involved too. Progesterone and testosterone are beneficial to bone health. And then when we think about cancer, we know that worldwide cancer is a problem. About 40% of deaths among women aged 50 to 69 are due to cancer of all different organs. But when we think about menopause and hormones and that sort of thing, breast cancer is generally the one that women are most concerned about. It generates a lot of anxiety, typically more than heart disease, even though more women die of heart disease. About 7 times more die of heart disease than die of breast cancer. But you can see that it's a significant number of women who are diagnosed with breast cancer. And certainly once we move into menopause, the incidence of breast cancer significantly increases. And then lastly, we're going to touch on dementia and Alzheimer's disease because there is a significant hormonal component here. Women who reach menopause younger than 45 years old have a higher risk of all-cause dementia, whereas reaching menopause later is linked to a lower risk of dementia. We know that estrogen in particular significantly reduces the risk of cognitive decline and Alzheimer's disease. Women on 10 years of estrogen therapy have up to a 50% reduction in the incidence of Alzheimer's, particularly when they've taken it for a duration of 10 or more years. And if you look at the research in terms of the type of hormone given, those bioidentical forms of estrogen and progesterone, meaning not conjugated equine estrogen and not progestins, result in a greater risk reduction than using those synthetic hormones. So when it comes to dementia, this is taken from the work of Dale Bredesen, who I think of as being sort of the foremost voice on Alzheimer's prevention and treatment. And he talks about why monotherapies for Alzheimer's have failed because the perfect Alzheimer's drug would have to address all of these issues. So his analogy is that, like, say we think of a roof with 36 holes in it. If it rains, water comes in through all those 36 holes. Monotherapy plugs just one of them. But if we're able to plug all those holes, and many of the things listed here are things that he screens for, then we have a better chance of preventing Alzheimer's. And you can see that all of the hormones that we typically test for are listed here. And there's increasing evidence that the pathology of Alzheimer's disease starts decades before we actually see clinical symptoms. And once we do see clinical symptoms, it means that there's already been significant neuronal loss and we may have less success with our intervention. So ideally, the time for both early detection and intervention is at the beginning of the prodromal phase, which can be functionally silent, rather than years later when we have symptoms. So waiting for symptoms can be harmful, and it really can be beneficial to start thinking about trying to prevent the development of this memory loss. And so I know a lot of you out there may be new to HRT or may not be comfortable using it. Today's lecture is really going to talk about using hormone therapies, not so much alternative approaches, although we'll nod at them. But I do want to talk about hormone therapy here. And if you're still feeling unsure about the safety of menopausal hormone therapy, probably since the Women's Health Initiative data was published a couple decades ago, I wanted to make sure you're aware that this data has been reanalyzed by the original researchers, and this reevaluated data indicates that estrogen actually protects against breast cancer while on it, and even 10 years after going off of it, progestins, those synthetic progesterone type molecules, progestins were actually the real problematic piece in the Women's Health Initiative. These increase the risk of breast cancer both while women are taking them and then up to a decade after having stopped them. Not only do they increase the risk of breast cancer, but also heart disease. Bioidentical estrogens don't share the same risk. In fact, conjugated equine estrogen didn't share the same risk. In the WHI, it was more the progestin piece. We know that women who were diagnosed with breast cancer while they're on these estrogen therapies actually have a better prognosis if they're diagnosed with breast cancer than women who have never been on the hormonal therapies. And large human studies have shown that natural progesterone, rather than the progestins, don't increase the risk of breast cancer and in fact benefit many, many tissues in the body. Okay, so in the conventional world, when these women go in to seek treatment from their providers, they may be offered these types of screenings. And so what I want to do today is try to think a little bit more broadly and talk about some additional functional tests and screenings that you might consider. So we'll talk about hormone testing, both in saliva and urine, neurotransmitter testing, gastrointestinal testing, a cardiometabolic profile, and then we'll briefly touch on methylation, micronutrient testing, and the adverse childhood experiences screening. So starting with hormone testing, when might you consider it? Well, because perimenopause is by definition something to do with hormones, probably all of these women. The symptoms that might lead you to do hormone testing are irregular periods, vasomotor symptoms, low libido, insomnia, cognitive concerns, mood concerns, vaginal dryness, migraines, things like that. But of course, some of the pathologies we would be hoping to prevent: osteoporosis, cognitive decline, cardiovascular health, and then to assess cancer risk. And this allows our treatments to be individualized. So some of the salivary profiles you might consider are testing sex hormones, testing cortisol, and including a cortisol awakening response, or CAR. And you can also test melatonin in saliva. So perimenopausal women are often having irregular cycles. Here are some ideas about how to collect and try to catch that luteal surge in cycles that are irregular. So in a 28-day cycle, which is textbook, ovulation happens about day 14. 7 days after that, day 21, is when we get the luteal surge, which is the point in the month when progesterone is at its highest. Estrogen and testosterone also have a little bump here as well. If there is irregularity, you can see some rules here. So essentially, the idea is that if ovulation occurs and that empty egg sac becomes a corpus luteum and secretes progesterone, that has a life of 14 days, plus or minus 2. That is established. So irregularity typically occurs in the follicular phase, not the luteal phase. So if you know someone ovulated, you can collect 7 days later. If you don't know if they've ovulated, then you try to calculate based on the length of the cycle. If cycles are very irregular, you just do the best you can. The truth is that once these women start to have very irregular cycles, even if they're bleeding, they may not be ovulating at least every month. So there may not be a luteal surge of progesterone to catch, but we still want you to try to catch it. Do your best so that we can see it if it's there. I find salivary hormone testing to be the most reflective of tissue levels, and so I rely on it for information on imbalances. Because fluctuating or low hormone levels can contribute to hot flashes, testing can be helpful. Low estrogen is often thought to be the culprit behind a lot of these hormone symptoms, like hot flashes, but actually it's the drop in progesterone that seems to really contribute to the symptoms of perimenopause. And I do want to urge you, quick little PSA here, I want you to get past the idea that progesterone is only beneficial to women who have a uterus. Hopefully you can see the benefits of bioidentical progesterone symptom-wide. I keep an eye on the androgens as well. We'll get more into that momentarily in terms of how they can also give us some insight into metabolic health. And then diurnal cortisol testing is a minimum test, in my view, for assessing the patient's ability to respond to stressors. So I wanted to share some stats here that illuminate the benefits of HRT in symptom management and disease prevention. So with mood concerns, 96% of women reported improvement. There have been, this is all, in the literature, almost all women can see benefits in vaginal dryness and atrophy, insomnia, cardiovascular risk, cognition, and osteoporosis. All will be benefited by hormone replacement therapy. But for those of us who do a lot more than HRT, these stats illustrate the benefits from HRT only. They don't consider all the other great things that functional docs provide. So that's good news for us. All right, we're going to take a little step now into stress and testing cortisol. And I wanted to talk a little bit about how to think about stress. So assessing stress or HPA axis health by measuring cortisol and DHEA is not the same thing as identifying the unique stressors that have contributed to that status or function. So we test cortisol to see how the patient may be resilient to stress or suffering some inability to be as responsive to stress. But then we have to identify the source of the stress. And so this is taken from the work of Tom Williams. When we think about stress, if I were to ask you, and I can't see you, but think about what is stress? You might be thinking traffic, marriages, children, finances. And that's true. Those are all stressful things. But if we look here at this diagram, those are just 1/4 of this circle. That's the perceived stress, right? These are the things that we think of typically as stress. What many of us don't identify is glycemic dysregulation, inflammation, circadian disruption. These are all stressors that can be identified and managed and can help us support our patients. So in addition to diurnal cortisol testing, which you guys are probably already familiar with, I want to introduce the cortisol awakening response, or CAR, if this is not something that you've already learned about. So what's cool about assessing the cortisol awakening response is that if we think about a diurnal curve, that's what we call a basal cortisol levels. Those are points in time, but they're not responding to stress. Luckily, the act of waking up in the morning is a predictable stressor. And so we can collect around that time to see how the person reacts to the stress of waking, which is indicative of how they may be responding to other stresses in their day. So we wake up, take a sample, collect 30 minutes after we wake up, because we know that 30 minutes after waking is the point at which cortisol is at its highest. And then we collect again at 60 minutes post waking. And so this allows us to see how the patient is responding to stress. We might see an elevated cortisol awakening response. Now, this is not necessarily maladaptive. What it shows is a very healthy or potentially even overactive response to stress. We do know that the CAR is typically more elevated on Mondays, on work days, on days when there is something that may be happening in the life. So I'm giving this webinar today. My CAR may have been higher this morning than it would be on a Saturday, for instance, because I was anticipating doing something stressful. There are other things that could lead to an elevated CAR, but essentially this tells us that no matter what's happening diurnally, there is a significant response to stress. Generally, that means that this patient has a little bit more gas in the tank, so to speak. Whereas if you had a blunted CAR, the opposite is true. So generally, if the body is unable to have a healthy response to that act, that stressful act of waking up in the morning, this means that they are more decompensated, right? There is significant burnout and inflammation. So let's look at how this might give you a little bit more insight. So this is actually a patient who had some fatigue, decreased mental sharpness, decreased motivation, tested their cortisol, and it actually looks pretty good, right? Except for this evening drop, everything is falling within that green optimal level. It looks pretty good. And I would probably think that there's not a lot of support needed here. But if we add the cortisol awakening response, we can see that it's blunted, right? So waking should be followed by an increase and then a drop that's a little bit lower than that waking level. But what we see here is that the difference between waking 30 minutes after waking and 60 minutes after waking is very blunted. What that means is that this patient is probably on their way to decompensating further, moving towards more of a phase 2, and would benefit from a more aggressive type of support than you might have initially considered for them. So when we think about the stress response, I want to remind you that there are contributions from neurotransmitters. Serotonin is a big one. So serotonin is involved in healthy HPA axis function because it actually facilitates the release of ACTH by the pituitary, which then promotes the release of cortisol and DHEA. So if we have low serotonin, that might actually contribute to low cortisol. Additionally, low serotonin can be caused by stress because stress can inhibit the tryptophan hydroxylase enzyme, which moves tryptophan into 5-HTP, which becomes serotonin. And then if we think about stress, we always think about cortisol, but we also have to consider the catecholamines. So catecholamines are dopamine, norepinephrine, and epinephrine, but epinephrine and norepinephrine are very involved in that stress response. So when I am really trying to do a thorough workup of stress in my patients, I will make sure that I'm testing both neurotransmitter secretion, which is a urine test, as well as the salivary cortisol levels, because we can see changes in both of these areas. So this is an indication of what an early, or say phase 1 stress response might be. So you may have patients who come to you with very similar symptoms: fatigue, depression, anxiety, trouble with focus, trouble with sleeping. These are commonly seen symptoms with HPA axis dysfunction or adrenal fatigue, which is not a correct term, but it's often used in this context. So because everybody fatigues at different rates, it's really helpful to test. So in the early stage of the stress response, you'll often see elevated cortisol as well as elevated norepinephrine and epinephrine, because we know that if you experience stress, so let's take that time-honored example of, say, you turn the corner and then you're faced with a snarling tiger, the epinephrine responds immediately, the cortisol comes in moments later. Both are very important in that response that allows us to fight or flee. But the sympathetic nervous system is not designed to stay in that high stress mode continuously for months and months or years. Some people may call this decompensation that we start to see adrenal fatigue, but it's not the adrenal gland that's fatiguing. Rather, the sympathetic response and the HPA axis begin to adapt to the constant onslaught of stressful stimuli. So at this point, when we test, you may find that some markers are high and some markers are low. So you may see cortisol levels start to slip a bit, and norepinephrine and epinephrine may start to slip. Now, I will tell you just from experience that epinephrine, of these two neurotransmitters, epinephrine is the one that tends to stay higher for longer, likely because it is such an essential piece of that stress response. Eventually, though, our patients will find themselves essentially very depleted, very exhausted. At this point, people generally don't feel very well because they've essentially got no gas in the tank. Cortisol levels are tanked, epinephrine and norepinephrine are very low. You typically will see this late stage type picture in patients who have been dealing with chronic high stress for long periods of time. The gold standard for cortisol testing is saliva, although it can be tested in urine, but neurotransmitters are tested in urine. Here's an example of our comprehensive neurotransmitter profile here, the one that includes metabolites as well as the neurotransmitters. So when might you consider neurotransmitter testing? We probably all think of it with mood concerns, issues with cravings or compulsions, issues with cognition, that sort of thing. But it can go further than that. You know, vasomotor symptoms, hot flashes and night sweats. There's a very big serotonin component here. Low libido can be sex hormones or neurotransmitters, that sort of thing. So essentially, anytime your patient is dealing with physiological or psychosocial stress, measuring cortisols and neurotransmitters will be of benefit. And I did want to point out that cognitive concerns are often amplified in the period of perimenopause. Anytime you've got these, times of great hormonal fluctuation. So we see it in puberty as well, maybe pregnancy, but certainly perimenopause, when hormones are fluctuating, people can start to have a lot of trouble with focus and attention. And in fact, adult ADHD is often diagnosed in this time because suddenly women who have found ways to compensate all of their adult lives suddenly are unable to do that. And there are some markers, some certain neurotransmitters that may help us in supporting patients who have issues with focus and attention. When you're looking at the neurotransmitter report, considering excitatory and inhibitory balance can be helpful and help you prioritize treatment. And a quick word about sleep, because poor sleep, of course, makes everything worse. And it often begins in the perimenopausal years, and then it doesn't really get better as we age. I mean, you can see here that sleep disturbance is actually a little bit higher in perimenopause than menopause itself. But across the board, once we start to enter perimenopause and beyond, sleep can be elusive. There's a whole lecture I do on what contributes to insomnia in perimenopause and menopause. So that list is here of all the things I consider, but you can see here a lot of the testing that we're talking about today can contribute to insomnia, or the imbalances we may uncover could be contributing to insomnia. And we can actually test melatonin in saliva. We know that it should rise in the evening and be high at bedtime, and then it'll start to drop in the morning once we get some sunlight exposure. If we see low melatonin at bedtime, then we can start to try to determine why. This is what might happen when we are exposed to a lot of light at night, especially the blue light that we get from screens, because it can suppress melatonin, making it harder to fall asleep and stay asleep. So what you might do in these cases is use light therapeutically, talk to your patient about sleep hygiene, but potentially also give melatonin supplementally. Okay, we've discussed salivary hormone testing, which I believe provides a better reflection of tissue levels than serum does. But I also wanted to talk about urinary hormone and metabolite testing, because this is also a really fantastic tool that can give you some more information about your patients. So in case this is our QMAP, our urinary metabolites profile. And if this is new to you, just a quick overview. We're able to test unconjugated and conjugated hormones, but mostly conjugated. So what do I mean by that? Well, the unconjugated hormones are the hormones in their sort of the state we would find them moving through our tissues: progesterone, testosterone, estradiol, etc. But in the urine, because these hormones are not water soluble, they're fatty, a lot of sidearms are added to make them water soluble. Usually this is a glucuronide or a sulfate molecule. And this facilitates their elimination in urine or stool, but some of them have physiological properties, and so we can track that in urine. I did want to talk quickly about the way we use colors in this report. You can see here that the reference interval is technically the green area, yellow and light blue, but we've got yellow and light blue marked because sometimes providers like to pay attention if levels are trending up or trending down. But frankly, elevated levels will be red, and frankly, low levels will be blue. So this will allow you to easily see at a glance the patient's highs and lows. So the metabolites that I pay specific attention to in this perimenopausal group are estrogens, specifically in terms of monitoring breast health, androgens, and then oxidative stress. So let me talk to you a little bit about these now. So in the estrogens neighborhood, some things we can monitor are aromatase activity, because estrogens are made from androgens like testosterone via the aromatase enzyme. And then they can go through phase 1 metabolism down the CYP1A1 and CYP1B1 pathway. We can monitor that. We can monitor the activity of the COMT enzyme, which methylates them, which allows us to evaluate the potential for DNA damage. And this is true for both endogenously secreted hormones as well as hormone replacement therapy. For decades, since the Women's Health Initiative was published, estrogen has been vilified for increasing breast cancer risk. Now that information has been reevaluated, we do know that estrogen is not the cancer promoter that we once believed it was. However, there is still some evidence that estrogen can promote cancer in some women. So if it's not estrogen itself, that's the issue. What should we be focusing on? Well, the Jenica study gave us some clues. It looked at things like age, hormone replacement use, menopausal status, BMI, et cetera. But they also looked at some of these urinary metabolites, and they found that premenopausal women with elevated 4-hydroxyestradiol levels had a higher odds risk of breast cancer than women in the 10th percentile. And so I wanted to point out that what we're going to talk about now, this is evidence-based. The 4-hydroxyestrogens increase cancer risk. They possess carcinogenic potential. They can cause DNA damage and form depurinating adducts, which can cause mutations and initiate breast cancer. The formation of 4-hydroxyestradiol was 4 times higher than 2-hydroxyestradiol formation in cancer. However, if these molecules are methylated, we can prevent that damage. This is research showing that the 2-hydroxyestrogens are associated with a reduced cancer risk. So you can see here up to a 28% reduction in cancer risk. And then again, back to the 4 pathway or the 1B1 pathway. It is implicated in the development and progression of estrogen-mediated tumors. Its overexpression is responsible for estrogen's conversion into toxic metabolites. So let's dive into why and how this happens. So estrogen metabolism primarily happens in the liver, and this takes place through a 2-phase metabolic process. Because this might be new to some of you, I wanted to take a minute to just walk through how this happens and how it can affect health. So remember, these hormones are fat soluble. They're made from cholesterol. We know that oil and water don't mix. Urine is a watery substance. So the fatty hormones that are made from cholesterol have to be conjugated to water-soluble side arms so that they can be excreted in the urine. So phase 1 metabolism begins this process of adding these side arms so that they're more water soluble and can be excreted. The problem is that these phase 1 intermediates are highly reactive. So my husband is a contractor and he does some electrical work, and sometimes he'll come home after doing this work and he'll have little burns on his fingers because raw electrical wires can, burn the skin if they're touched. And it occurred to me that this is similar to phase 1 metabolism. When we have these hydroxylated metabolites, they're very reactive, meaning anything they touch, they could cause damage to. So it's helpful to monitor them. There are 3 main pathways we follow: the 2-hydroxy, 4-hydroxy, and 16-hydroxy pathways. The 2 pathway is generally considered to be the safest. That's metabolized via the CYP1A1 pathway. 4-hydroxy metabolites, both estrone and estradiol, considered to have the greatest potential for DNA damage. Those are moved via the CYP1B1 pathway. And then the 16-hydroxyestrone, which we see here, also has the potential for DNA damage, a little bit less so than the 4, however. So you can see the 2, 4, and 16 ratios are represented here in grayscale in terms of their relationship to one another. And then these pathways allow us to see how the hormones are moving. And the color coding shows us if we have low amounts of it, within range amounts of it, or in this case, we don't have any yellow or red, but that would be an abundance. So here is our estrogens pathway. CYP3A4 is the enzyme that makes 16-hydroxyestrone as well as estriol. CYP1A1 makes the 2-hydroxy pathway, CYP1B1 the 4. These little snippets here are taken from our HUMAP Therapeutic Considerations support document. You can see everything listed by a minus sign means it could slow the activity of the enzyme. Things listed by the plus sign means it would support the activity of the enzyme. So when we think about movement down CYP1A1 and CYP1B1, which make 2-hydroxy and 4-hydroxy metabolites, a mnemonic to help you remember which one is good and which one is bad is that CYP1A1A is awesome, CYP1B1B is bad. CYP1A1, the awesome pathway. This is the healthy pathway. It pushes estrogen towards the safer catechol. Now, giving DIM to support movement down this safer pathway is probably something you're familiar with. DIM supplementation will enhance movement down that 2-hydroxy pathway. So we'll see an increase in the levels of the 2-hydroxy metabolites, and that also can lead to reduced production of those 4-hydroxy metabolites, which are carcinogenic or potentially carcinogenic. Now, the CYP1B1 pathway, the bad pathway, pushes us down the more unhealthy 4-hydroxy metabolism, where we can activate more cancer-promoting compounds. In fact, research indicates that CYP1B1 is more readily found in tumor tissue compared to normal tissue. So a lot of us will turn to DIM to help to support movement down that healthier pathway. And you're actually able to see a response with testing. So here's a patient who had very high levels of the 4 metabolites in comparison to the 2 and 16. After 6 months on DIM, the ratio between the 4-hydroxyestrone to 2-hydroxyestrone, so the dangerous to the safe, had been improved and moved into more of a safe range. So DIM can be very efficient and effective. Now, the CYP3A4 pathway, this is one's a little bit less straightforward. We know that this can lead to the 16-hydroxyestrone, which does have some estrogenic activity. However, CYP3A4 also helps us make estriol, which is a very healthy estrogen. And so I'm just, this one is a little bit more nuanced in terms of supporting it, but definitely something that you're going to want to consider. So once the body has made 2, 4, and 16 metabolites and whatever ratio they have, then they move into phase 2 metabolism. So these essentially move on to inactivate those reactive intermediates, those reactive hydroxy intermediates. They add additional side arms to increase polarity, which increases water solubility, but it also reduces toxicity so that we can safely eliminate these metabolites. Methylation is a really common way to cap the dangerous reactivity that we can see with the 2, 4, and 16 hydroxy metabolites. Once we cap these wires with methyl groups, they're no longer dangerous. So looking at these pathways again, even, if you're going down the awesome pathway or the bad pathway, either way, COMT, catech-O-methyltransferase, which requires methylation, will help to cap any metabolites so that they're inactive and can be safely excreted. So again, will these things be oxidated or methylated? Oxidation leads to quinone and semiquinone formation, which can damage DNA. Methylation inactivates these catechol estrogens so that they can be safely excreted, safely leave the body. So again, if they're not methylated, they can lead to these quinones and semiquinones, which can result in DNA damage, increased carcinogenic potential. I think this last bullet point is really important, so I'm going to read it. Research indicates that increased amounts of estrogen DNA adducts are found not only in people with several different types of cancer, but also in women at high risk for breast cancer, indicating that the formation of adducts is on the pathway to cancer initiation. So again, back to this idea that when these perimenopausal women come to us, we can help them manage their symptoms, essentially help them manage their now, but we can also get information that helps us protect them against developing various pathologies. And in this case, this urinary metabolite information can help us with the prevention of breast cancer. So monitoring this methylation activity is really important. And I wanted to just show you here that just monitoring the 2 pathway is not sufficient, because you can see here that they don't always methylate at the same rate. I don't know why this happens, but I can tell you we observe it all the time. So monitoring every pathway that we can is really important, because If we had just looked at the 2-methoxyestrone to 2-hydroxyestrone, which is methylating quite well, we might think that this patient was very protected, but in fact, we can see that in this 4 pathway, methylation was not quite as efficient, and so methyl support would likely be beneficial here. So how do we support the COMT enzyme that methylates these? Well, with cruciferous foods, soy foods, things like that, you've got some food support listed here. And then if we wanted to also give some supplemental support, you can see some ideas listed for you. So let's move over to our androgens neighborhood, things like testosterone. In urine, we're able to evaluate enzyme activity. So the two primary ones are aromatase, which turns testosterone and androstenedione into estradiol and estrone. So we can monitor aromatase, but also 5-alpha versus 5-beta metabolism. We can look at 5-alpha DHT and 5-AAD. These are two metabolites that are more responsible for things like acne, scalp hair loss, mood instability, belly fat. So it's not just looking at the amount of testosterone present, but how much DHT is present, how much 5-alpha AD is present. It's a little bit of a deeper insight into what might be causing the symptoms that our female patients are experiencing. And then the HUMAP also assesses oxidative damage by measuring the 8-hydroxy-2-deoxyguanosine, because if your patient is exhibiting elevated levels of 4-hydroxy metabolism and is not methylating appropriately and also has a lot of oxidative damage, that is a recipe for cancer, and you can intervene. Okay, so now let's return to the idea of the detox process. We've talked about phase 1 and phase 2, and now I want to talk about phase 3, elimination. So this is when breakdown products leave the body, either in urine or stool. So this is a great diagram because it shows you some of the nutrients that are needed to support phase 1 and phase 2 metabolism. And now we're going to talk about phase 3 in terms of stool. These things leaving the body via stool, because we really need to address phase 3 first. Because if you identify some imbalances with the HUMAP test and you give them DIM and you give them methyl support and you do a lot of work to improve the way that the hormones are being excreted, but GI health is not good, you may not be supporting them as efficiently as you should, because if they're constipated, for example, there may be time for them to reabsorb these estrogens that you and the patient have worked so hard for them to excrete safely. So we have to consider GI health in all of these women. So a lot of these women don't have symptoms of, gastrointestinal distress. Maybe they have diarrhea, maybe they have abdominal pain, maybe they have stuff like that. But I would consider GI testing if they're estrogen dominant. If you find imbalances with urinary hormone testing, if they're stressed, if they have autoimmune disease or joint pain or neurological conditions or mental health concerns, GI imbalance affects really every body system. And one of the main players is the microbiome. So we know that in a healthy gut, the majority of the flora are beneficial. They release positive signals to our brain and their body, and they keep the bad or the troublesome flora in check. Maintaining that balance can become more challenging, though, once our estrogen levels start to fluctuate in perimenopause. And if that bad bacteria starts to take over, we can start to see its negative effects. Now, that may be in mood, that may be with weight, metabolism, really anything that is affecting their overall health picture. And we know that as women's hormones start to decline, the makeup of the gut flora actually changes. And if things get too out of balance and harmful bacteria take over, we can get into what we call dysbiosis, and that can lead to disease. And scientists, this is still a relatively new area, and scientists are exploring how having a gut that's out of balance can affect anything from cancer to polycystic ovarian syndrome and everything in between. Now, as we have less estrogen, we will see less microbiome diversity. So in cycling women, they typically have a very robust gut microbiome. This generally peaks about age 40. And then once hormone levels start to decline, the gut population begins to look like men, essentially. And a more diverse microbiome is beneficial because it can help protect us against germs and various things that can lead to disease. In fact, in a 2023 study, researchers at Oxford University found that the more kinds of good flora you had, the quicker invading bacteria was shut down. Postmenopausal women tend to have more microbial strains that studies have linked to obesity. And so we should all pay attention to this, right? Because I don't know a single woman at any age, really, but certainly in perimenopause, who is not concerned about her weight because it becomes much more challenging to manage it and maybe nothing has changed, right? Women will come to us and say, nothing's changed. I haven't done anything different. And suddenly I'm gaining 5 pounds, 10 pounds. I just can't lose it. Well, what's changing is our hormones are changing, right? And that can impact a lot of different areas. And one of them is gastrointestinal health and the balance between good and bad bacteria. Once we get too many of the bad strains, we can see changes in mood, changes in the things that we have cravings to eat. We know that menopausal women have lower amounts of rhinococcus, which is a big producer of short chain fatty acids. Short chain fatty acids help with inflammation management and a whole host of things. Researchers also noticed a dip in the level of firmicutes, which can aid in getting nutrients, regulating hunger, and feeling satisfied. Researchers have also found that some of these changes in the microbiome can also help explain why a lot of mood concerns start to be a big issue in perimenopause. In China, some researchers found that premenopausal women with depression had 14 times more Klebsiella, which is a flora that will rapidly break down estradiol and clear it from the body. And this left these women with about 43% less estradiol than women who were not depressed. And in another study, researchers found that women with perimenopausal panic disorder had an imbalance of bacteroides and allosterics. And while both of these can be beneficial, if they're there in too large of an amount or overabundance, then you can see a problem. So how do you assess the microbiome? With the GI 360. So here's an example of the summary page of the GI 360. So this web lists 6 groups of bacteria that are very impactful. And you can see here, here's the key. So this dark green area would be the optimal point of microbiome dispersal or disbursement, and then so if the webbing is pulled in, it means there is too little of that family, and if it's pulled out, too much. And all of this can contribute to the dysbiosis index and the diversity score. So dysbiosis of 3 or higher indicates dysbiosis, meaning generally that there's too much of the bad and not enough of the good. And then a diversity score should be 3 or higher. If you have low diversity, that means there's not enough of various strains of bacteria for you to have a healthy balance. Another thing to keep an eye on, just in terms of how it can contribute to hormone balance, is the beta glucuronidase. Dysbiotic guts will often result in higher amounts of beta glucuronidase being secreted, and beta glucuronidase is an enzyme that can cleave estrogen molecules that have been excreted. So these are the ones that have been, hydroxylated and methylated and then excreted, but beta glucuronidase can cleave those sidearms so that the estrogen can be reabsorbed and recycled. The body is an incredibly efficient recycler, and it wants to recycle these hormones if it can. So we have to make sure we have a healthy gut that is not secreting high levels of beta glucuronidase, so all of those bound hormones can be excreted as intended. Intestinal permeability can also lead to problems, inflammation, etc. And so if you suspect intestinal permeability or leaky gut, you can do a serum zonulin test, which lets us know how leaky that gut might be. So an understanding of exactly how the microbiome contributes to chronic disease is evolving, but there is evidence that dysbiosis and issues with gastrointestinal health have been associated with cardiovascular disease, cancer, diabetes, and even Alzheimer's, saying here that our microflora may act as a second brain. So we've got to pay attention to it. How do we support these women? I bet everybody in attendance here is familiar with the first three. We got to eat a good, healthy, anti-inflammatory diet. The Mediterranean diet is typically thought to be the best example of that. We want to avoid those foods that are inflammatory, like the processed foods. And then we want to address any issues that have been identified with the microbiome test, the GI test. Is there a pathogen? What is there too much inflammation? Is there blood? Right? We want to address these things that we find. But what about the fourth bullet? Have you been considering HRT? There was a study in 2022, and researchers compared the upper small intestines of premenopausal women and menopausal women on hormone therapy, as well as menopausal women not taking hormones. And they found that the women on hormones had more diverse gut flora and a similar mix as the premenopausal women. So those changes that to the microbiome that are seen in menopause can essentially be reversed if HRT is used appropriately. All right, we're going to move to our next test now, which is cardiometabolic testing. So who would benefit from cardiometabolic testing? Well, since heart disease is the number 1 killer of women, I would argue that all of them would, but certainly anyone who has a family or personal history of cardiovascular disease, if there is obesity or excess abdominal fat, insulin resistance, fatty liver disease, elevated androgens, cognitive concerns, poor methylation, and hormone imbalance. So in a conventional laboratory assessment, generally things like blood sugar will be monitored, generally with a hemoglobin A1C. Cholesterol is measured, and generally that includes total cholesterol and HDL and an LDL. Triglycerides and inflammation may be via CRP or HSCRP, but Doctor's Data offers you an expanded profile. This is our cardiometabolic profile. This is a serum test, and you can see here that we've moved beyond just the traditional cholesterol trigs type assessment. There's a lot more information here. So let me tell you a little bit about some of these expanded markers. So oxidated LDL is a strong independent risk factor for cardiovascular disease. So how much of the LDL that you have has actually been oxidized, which is problematic. Small dense LDL is very atherogenic because those small LDL molecules can really get into the walls of the endothelium. LP little a is a genetic independent risk factor for premature heart disease, thrombosis, and stroke. ApoA1, this is considered the good one because it is anti-atherogenic. It's made from HDL, whereas ApoB is the bad one. It is made from LDL, and in fact, some people consider it to be a more accurate prediction of atherogenic risk than LDL-C, non-HDL, or any other marker. This expanded profile gives you 3 markers of inflammation. You're probably already familiar with homocysteine and high sensitivity CRP, but the plaque provides an indication of very significant atherogenic disease activity, inflammation, and if there's an increased risk for rupture of advanced plaque. So it's essentially giving you insight into inflammation in the vessel itself. And then serum 1,5 and hydroglutatol, sometimes known as glycomark, which is a trademarked name, gives you an estimation of the previous 2 weeks of glucose. So whereas an A1C gives you about a 3-month average and a fasting insulin gives you an in-the-moment level, this marker gives you about 2 weeks of glucose control. So it's just another way to get an idea of what's happening with glucose. And then the adipokines are tested via leptin and adiponectin, which give a little bit more incidence or insight into satiety, cravings, our propensity to develop something like metabolic syndrome and diabetes. Okay, we're going to move on to methylation testing now. So we talked about the importance of the COMT enzyme with metabolizing estrogens. It's also important in neurotransmitter health because COMT metabolizes our catecholamines, dopamine, epinephrine, and norepinephrine. But methylation is important system-wide. We know that poor methylators have an increased risk of cardiovascular disease and cancer. They may not detox very well, so they've got more oxidative stress. So there is a lot to consider when we think about our patient's ability to methylate. So doctor's data offers you two options here. Our DNA methylation, oh, excuse me one second. Lost my second screen. Okay. Our DNA methylation profile, this is a buccal swab, and this essentially identifies various SNPs that could make it more difficult for your patients to methylate. But the methylation profile tested in plasma is more of a functional assessment of the phenotypic expression of common SNPs. So this one on the left is our genetic issues, but the one on the right tells us how the genes are affecting us functionally by monitoring methionine, cysteine, SAMSA, homocysteine, et cetera. So that can be a really beneficial profile. And I'm going to briefly touch on micronutrient testing, fatty acid testing, and red blood cell elements. All of the things that might lead you to run these tests are listed here. But just to touch on them quickly, with red blood cell elements, red blood cell analysis really can be invaluable for assessing insufficiency or excess of elements that have important functions either within cells or on red blood cell membranes. So an important feature of this analysis is that the cells are not washed, because this could potentially result in the loss of some of the important elements, such as calcium, that bind to the plasma membranes. But red blood cell elements can be useful. So for cardiotonic influences, we generally think about magnesium and potassium. For anti-inflammatory processes, we think about selenium, copper, and zinc. With anemia, we generally think about copper and iron. For immune function, zinc, copper, and magnesium. And then with glucose tolerance, chromium, manganese, and maybe vanadium. And for fatty acid analysis, it's really well established that appropriate balance among essential and non-essential fatty acids, as well as the avoidance of trans fats, is required for optimal health and wellness. And the typical Western diet just has more omega-6 fatty acids than omega-3s, which are healthier. So monitoring the amount of both can be really helpful, and also monitoring the levels of arachidonic acid. So some ratios that are given for you are the arachidonic acid to EPA ratio, and then also the DGLA to arachidonic acid. These ratios indicate often inflammation and what type of fats your patient should increase or decrease with their diets. All right, I'm going to take a moment now just to talk about the Adverse Childhood Experiences screening tool. This is not something that Doctor's Data offers, but I think if we're going to be comprehensive with patient management, it really is something important to consider. And once I learned about this research, my whole approach to patient management changed. So if this is new to you, this is a really quick overview, but I consider it with all my patients. In fact, it's part of my intake paperwork. So this comes from a study published in 1997 through Kaiser Permanente. It was one of the largest investigations of childhood abuse and neglect and how that relates to later life health and well-being. So there were over 17,000 HMO members from Southern California. This was their San Diego location. And they completed confidential surveys regarding their childhood experiences and their current health status and behaviors. So at the time, these were the 10 things that they were asking questions about: whether as a child there was physical, emotional, or sexual abuse in the home, whether there was physical or emotional neglect, and if there was mental illness, an incarcerated relative, violence towards the mother, substance abuse, or divorced parents in the home. This is the screen. It's a 10-question screen. Every positive response is given a score of 1. And as the number of ACEs a youth experiences increases, so too does her risk for health problems. So this is widely available on the internet. There's a link at the bottom of this slide that'll take you to one, but they're easy enough to find. These are some of the important findings. Compared to people with no childhood trauma, people who scored a 4 or more were twice as likely to be diagnosed with cancer or heart disease, 7 times as likely to be alcoholics, 6 times as likely to have depression, 12 times as likely to have attempted suicide. People exposed to 6 or more traumatic events die 20 years sooner than those who had none. This is mind-blowing, isn't it? Mind-blowing. One prospective study found that poor emotional functioning assessed at age 7 was associated with higher C-reactive protein, which is inflammation, at age 42. So essentially, things that happened to us as children, if we weren't supported well enough, if we didn't have enough resilience, can affect our adult health. And if we're not screening for it, we may never know. We may just find that these patients are just not quite getting better. We can't figure out why. Maybe examine the number of ACEs they have. All right, let's talk about some of the imbalances with the testing that we've talked about today. So these are salivary hormone profiles. In the perimenopausal years, we commonly see anovulation, which means less progesterone. Estrogen levels can also fluctuate. They often begin to decrease, but not necessarily, because we can make estrogen in our periphery via aromatase. Often if we, you don't have to have more adipose tissue, but if you do have more adipose tissue, it increases the likelihood. So I do want to test estradiol levels, but I also want to test progesterone. That's very, very important. And you can also test some additional estrogens, estrone and estriol. This allows the estrogen quotient to be calculated. You can see in this example, it's within the reference interval, but in this example, it's not. The estrogen quotient, which looks at the influence of estriol in relationship to the more proliferative estrogens. This is another way to assess breast cancer risk. I like to monitor, as well as the estrogens and progesterones, the testosterone and DHEA levels, because these often decrease in the perimenopausal years. But if the patient is dealing with polycystic ovarian syndrome or insulin resistance, dysglycemia, or metabolic syndrome, what we often see is androgen levels rise. And in these two examples, you can see how testosterone and or DHEA are elevated, and sometimes that can contribute to more robust estrogen levels. So I find it really important to test these perimenopausal women, even though hormone levels may be fluctuating, because there's a lot of information that we can gather. Saliva will show elevated levels of testosterone or DHEA if there is insulin resistance metabolic syndrome, but urine testing can provide some additional information because it can highlight 5-alpha reductase activity. So you can see here 5-reductase activity is what turns testosterone into DHT, that more reactive testosterone molecule, as well as 5-alpha AD, which gives us a little more insight into cells that have utilized DHT. And here's 5-beta over here. So we look at the amount of the 5-alpha reductase markers in relationship to the 5-beta reductase markers. And this lets us determine if the patient has an overactive 5-alpha reductase enzyme. And if so, there's some things we can do to intervene. Saw palmetto is a very common herb that's used in these cases. All right, let's look at some examples of cardiometabolic profiles. So here's a 48-year-old who is a little bit overweight, has some abdominal adiposity, which we know is really not ideal for cardiometabolic health. And she's following a ketogenic diet because she was told that can help you lose weight and might help you with some, of the elevated lipid markers. But we can see here that that's not necessarily happening. So the way to read this is if the patient is landing into green, that's low risk, red is high risk, and then you've got this moderate area. So here we can see that triglycerides look good. HDL looks pretty good at 60, but there's a lot of LDL. There's a lot of oxidized LDL. There's a lot of small, dense LDL. We've got some inflammation here with this plaque marker. The glucose and the 1,5-anhydroglucitol appear within normal limits, so that's good, but there's low insulin. That's an interesting finding that you can sometimes see in the presence of ketones. So having a ketogenic diet is potentially one way to help manage obesity, but does not necessarily mean that the lipids will be optimal. So good to take a look. Now, I like this little snippet because this is a 45-year-old woman who eats a standard American diet and her lipids were elevated, so her doc put her on a statin. She kept eating her standard American diet thinking the statin was taking care of everything. And we can see There are some benefits from the statin, right? Her total cholesterol looks good, but the HDL is not great, right? She's at high risk. It's a little lower than we would like to see it. Hers is 38. We want it to be over 50. We can also still see some oxidized LDL, some inflammation here. So even if someone is using therapies like a statin, if we look a little more deeply, there could still be some areas where we could support them and improve their overall health. Now, what about gastrointestinal testing? Again, we want to think outside people who are having gastrointestinal symptoms. So this was a 45-year-old patient of mine who had no GI complaints, but she did have significant stress. So if we look here at her web, we can see that there's too little of some of these phyla. She has moderate dysbiosis at 3, but very low diversity. So that means that this could be improved. Generally, we'll do that through diet. And these are functional guilds. We didn't really talk about these yet, but essentially it looks at different groupings of bacteria that can produce butyrate, protect the integrity of the gut, lead to inflammation, etc. And all of these were imbalanced. And then here is reported out the various things that they found. She had some low short chain fatty acids. There was a little bit of occult blood detected. That can sometimes mean esophageal varicosities or even a stomach ulcer. And then they cultured out 2 pathogens. So there's a lot going on here, even though she had no symptoms, but she's complaining of stress. We know that inflammation is a significant contributor to that feeling of stress and the way it can also affect cortisol, epinephrine, and norepinephrine. So to dive a little deeper with her, Akkermansia is considered to be very protective, especially to mucosal barrier integrity, and she has low values here. Increasing that could potentially help with weight management, glycemic control, et cetera. And then she's got too much of these proteobacteria and Escherichia species. Those are very inflammatory. And then looking at zonulin, we can see moderately high, which means there could be some leaky gut going on. So lots to work on here, even though she had no symptoms. Also low elastase, which means she's probably not digesting her food as well as she should. And we can see here low short chain fatty acids, which can lead to inflammation. So a lot of things were uncovered in this GI test that are contributing to stress, in addition to the things she considers to be stressful, which are generally those perceived things. When people eat a standard American diet that's high in fat, low in fiber, generally what we see is more of a trend towards dysbiosis and low diversity and a lot of issues with the functional guild. So this is pretty common if people eat a crummy diet. And then if they eat a healthier diet, and again, the Mediterranean diet is generally one that we hold up to be, of one to emulate, then we'll see better diversity and lower chance of dysbiosis, and they'll work appropriately, right? Low inflammation, good butyrate production, etc. And just another nod to fiber when it comes to addressing any imbalance in the GI, but with the microbiome, we want to think about soluble fiber, not just insoluble. So the soluble fiber is the part of the fiber that actually gets gelatinous, and it's what feeds the microbiome. We should aim for 8 to 15 grams a day. These are great sources: red kidney beans, lima beans, chickpeas, inulin, Jerusalem artichoke, garlic, onions, and bananas. The less ripe, the better. These support the butyrate producing bacteria, and we know that butyrate's really important. The other short chain fatty acids as well, but particularly butyrate to nourish those enterocytes, regulate inflammation in the immune process, and maintain mucosal barrier integrity. Hummus is a great option. Okay, so in conclusion, we always want to address our patient's symptoms. That's sort of a no-brainer. But I do think the perimenopausal years are a unique opportunity for us to try to prevent the pathologies that are more common as we age and move beyond our cycling years. So if osteoporosis is a concern, you would likely consider hormone testing, micronutrient testing, and GI testing. If breast cancer is a concern, hormone testing, GI testing, methylation, and micronutrients. Cardiovascular disease, you would likely want to do a cardiometabolic profile, but also hormone testing, methylation, micronutrients, and GI. For dementia, hormone testing, cardiometabolic, GI, micronutrients, and methylation. And really just another plug here for managing inflammation, better yet, identifying it so we can manage it at the source. And these are, there's a paper that I really love. I include it in a lot of my lectures, but these are the various areas that they stress are really important for us to monitor to try to identify inflammation. And so I've listed those for you here. Because perimenopause is a time of great change, physical and emotional symptoms begin to emerge, and functional testing provides an opportunity to not only improve the patient's now, but also the patient's resilience against the development of the significant pathologies that are more common in menopause. Okay, thank you for your attention. I think we have time for a few questions.